Good afternoon, everybody. I want to welcome you to the Henry Ford Transplant Institute lecture series. And today we have the privilege of having Dr. Adam Bingaman, who is from the Texas Transplant Institute in San Antonio, and with the topic on maximizing living donor and compatible kidney transplants. Dr. Bingaman has established an amazing track record in the world of transplantation. He had his training at Emory University, and we've had quite a bit of relationships in the past with Emory, with some of the surgeons coming from there, and subsequently moved on to San Antonio, at UT San Antonio, and subsequently to the Texas Transplant Institute. His background was flavored with a strong base in transplant immunology that led to a lot of the activities and research in that area with incompatible kidney transplant. But I would say that his background in both the science and administrative creativity led to the Texas Transplant Institute to have the largest kidney program in the country for many years running, and the largest living donor kidney program as well. From that, they've had many experiences, not just on clinical side of things, but also tactical. And with our initiative on the Center for Living Donation, it's a perfect time for us to hear about his thoughts on the subject. In addition to that, Dr. Bingaman has devoted a fair amount of time to leadership work and organized medicine work. He's a Region 4 counselor now and sits on the UNOS board and also sits on the living donor committees, and he's very influential in that space. Always presents fresh thoughts out of the box, and we're looking forward to hearing from you, Adam. Please join me in welcoming him.
Thank you. Thanks very much. So good afternoon, everybody. Can you hear me in the back? Good. So thanks for the invitation. It's a real pleasure to come to a transplant center like this and learn about what you all do and share what we do in San Antonio. So thanks for the invitation. So what I'm going to talk about today is this concept of maximization. I tell people there's about 240 kidney transplant programs in the United States. And, we do live donor transplants, and that's nice. But my question is, are you doing enough? Are you doing as many as you can? And so this concept of doing something is a very different concept than maximizing doing what you're doing. And that's really been our focus, is not just doing live donor transplant, but doing as many as we can. Not just doing incompatible transplants when folks aren't a match, but doing it as many as we can. And so that's really going to be the focus of what I'm going to talk about. So why is it important to be banging on this concept of maximization? And of course, the reason is this. I actually think it's shocking that in the United States, 4,628 people died on the waiting list last year. Because actually, these are some of our best patients. Most folks on dialysis never even make it to the list. So these are folks that died on the list that their doctor thought that they were good patients for transplant. They came to the transplant center. Transplant center thought they were good patients. We mailed them a letter that said, congratulations, you're on the list. And then they died before they got a phone call saying a kidney was available. What about these folks? 4,747 people that made it to the list got a subsequent letter in the mail that said, I'm sorry, we've reevaluated your history and you're no longer a candidate. We're taking you off the list. So in the United States, last year, over 9,000 people who were originally thought to be good for the list either died or got taken off. So this is a tragedy in the United States. And why is this happening? Well, it's happening, of course, because there aren't enough kidneys to go around for everyone that needs one, right? Everybody knows that. And so here's the accumulation of how things are working out in the field of kidney transplantation. There are now just over 96,000 people on the list. There's 13,430 kidneys to go around. And so that's pretty simple math to figure out that we've got a huge supply and demand issue. Now, this is a cumulative curve. I like to look at it a little bit differently. So let's ask this question. What's our annual deficit? Right? How many kidneys are available every year, and how many people in the transplant community do we think could benefit from one? So let's look at that. Here are the number of folks that are added to the waiting list every year in the United States over the past more than 10 years. And that number's evened out more recently at about 35,000. So every year, about 35,000 people are added to the waiting list. That number's gone up by about 20% over the last 10 years. And how about the number of transplants that are available? So this is the total number of kidney transplants done. That number's gone up about 8%, so rising at not as high a rate. And last year, there were just over 17,000 transplants done in the United States, kidney transplants, right? So here's our deficit. Every year, about 35,000 people get added to the list, and about 17,000 transplants are done. So every year, we run a deficit in the United States of about 18,000 kidneys. 18,000 kidneys is our deficit every year. So if we're not in the business of maximizing transplants, we probably should be, because there's a lot of need out there. So what can we do? So the truth of the matter is there's really only 4 things we can do. There's 4 things that everybody in this room should be doing to deal with this issue. Right, so the first is we need to decrease the need for transplant, right? So there's too many folks with kidney disease, right? We need to get out into our communities and push health initiatives, right? We need to push diabetes prevention initiatives. We need to get into our schools and talk to young folks about living healthy lives, right? We need to do that. We need to increase the supply of kidneys. Donate Life America, Donate Life Michigan has been very successful in getting people registered to donate. We need to get out into our communities and encourage people to register to become organ donors. In the United States, roughly 3,000 kidneys are procured every year and not used and buried into the ground. Because we worry about outcomes and we've got inefficient processes to place these kidneys that may be somewhat marginal, and that's an area that we need to work on. And then, of course, we can increase live donor transplant. We need to be working on all 4 of these issues in the transplant community to deal with this horrible problem of all these folks dying and being taken off the list because there aren't enough organs to go around. So my center is really concentrated on this issue of living donation. And the truth is, when I see people in the clinic, I tell them the most important question I ask is this: do you have anybody that can donate a kidney to you? Right? That's the most important question, because if you've got someone that can donate a kidney, then you don't have to wait on the list. And of course, kidneys from living donors work better and last longer than kidneys from deceased donors. So you might say, okay, I get it. So there's a lot of people that need transplants. There aren't enough to go around. People are dying. So I would guess that around the United States, folks are doing more live donor transplants, right? Wrong. Turns out live donor transplant in the United States is shrinking, down 11%, peaked at over 6,500 live donor transplants, and last year, just over 5,700 live donor transplants. So the need is great, and yet live donor transplant in the United States is shrinking. Why is this happening? Well, that's a complicated discussion, but I'm going to just point out a few things. And I guess in just a few words, it's not easy. And it's not easy to do not easy things. You know, to donate a kidney, I like to say sometimes that you've got to be healthy and wealthy, right? Because the donor has to be perfectly healthy to donate, and there's no mechanism for folks to get reimbursed to take time off, for example, or for travel. There's limited mechanism in a need basis, but for the average person, that's not compensated. So donors have to be perfectly healthy. Well, who in the United States is getting healthier and wealthier? Maybe not so many people. So maybe that's certainly a contributing factor toward live donor transplant going down. But we don't have any risk tolerance for living donation, and we really shouldn't have much. We have to have some risk tolerance. But, you know, it seems like when you sit in these live donor committee meetings and you're thinking, is it safe for the donor to donate? Half the meeting you think, I don't know, the person's a little too young, I'm a little worried about that. And then the other half the meeting you're like, I don't know, the donor's a little old, I'm a little bit worried about that. So we've got all these concerns, African American donors, donors that have some obesity, maybe pre-diabetes, maybe everybody in their family has hypertension or diabetes, so we worry about these folks. And so this is something that limits donors getting passed to donate. And then I talked about these disincentives to donate. There isn't reimbursement for travel, lodging, time off. There is on a need basis, but that's a very, very limited group of folks. And so live donor transplant in the United States, sadly, has been shrinking. And so we've got to do something in the transplant community to turn this around, to maximize live donor transplants, to look at our own programs and ask, is there something that we can do tomorrow that we didn't do yesterday that will allow us to do more live donor transplants? How can we turn some of these ideas into action? How can we maximize the utilization of the resources that we have to maximize the opportunity for transplant? Fine. So people like that idea until they start thinking, well, what do you mean by maximize utilization of resources? Like how much resources? And when you talk about, well, we're going to do more live donor transplants, well, like how many more? Right? So I get that. Listen, I don't get involved in anything unless I do some sort of a mental calculation of the climb-slide ratio, right? Because if I'm going to tell you to hire 10 more people and institute all this change, and then we're going to do 3 more live donor transplants at the end of the year, nobody's going to want to do that, right? On the other hand, if I tell you, well, listen, you might not have to hire anybody else, but you can just maximize the efficiency within your systems, tighten things up a little bit, change some focus, and then you're going to do twice as many live donor transplants. That may be worth it. So what is the climb-slide ratio in this business? Well, here's what happened in my center. In that same time period, live donor transplant at Methodist Specialty and Transplants more than doubled. In 2007, we did 71 live donor transplants, and we decided to focus a little bit. And in 2008, we did 94, and in 2009, we did 162. So the climb-slide ratio in this business works out well. And so the question is, what happened? So what I like to say is a lot of things happened, but what really happened is we really focused on excellence in every single one of the pieces of our live donor program with this concept that excellence drives growth. So I'm going to talk a little bit about what I think it takes to run an excellent program, to be able to grow a program, to maximize the opportunity for transplant for our patients. And it starts with this, right? So you can have great systems, but the truth of the matter is if the foundation of your program or the culture of your program doesn't believe in live donor transplant, it's going to be hard to grow anything. So it starts with culture. So we recognize that. And that culture has to exist both within the transplant center and the community, right? And so most programs may have parts of this, and communities may have part of this. But I've heard all of these reasons why centers can't do lots of live donor transplants. Well, we have short waiting times. You know, our waiting time's only 2 or 3 years, so we don't really feel like we need to do live donor transplants. And my response is, well, 2 or 3 years on dialysis is only a short waiting time if it's not you who's waiting, right? So I don't think that that's really a reasonable argument. Risk aversion for donors. Well, look, it's not 100% safe to donate a kidney, so we have to have some risk tolerance, and you've got to have folks in your program that understand the actual risk tolerance that we're able to accept for donors, and then out into the community. Certainly, you've got to have buy-in or support from local faith groups, from local racial or ethnic groups, from nephrologists and their partners, and from dialysis units. And if you get out into these areas and they don't believe in live donor transplant, then you're going to have to spend some extra time, and it's going to take that extra time, may even take years, to be able to grow that education, to be able to change a live donor culture within a center or a community to be able to buy into live donor transplant. And this is something that must happen at every center. You know, my population is about 65% Hispanic. It wasn't long ago, maybe 6 months ago, I was at a national meeting. I sat through an entire 30-minute lecture of somebody lecturing me about how Hispanic patients don't like to donate. Maybe his Hispanic patients don't like to donate. I run the biggest live donor program in the country off the back of Hispanics. So our cultures are different. And if your culture is, oh, well, you know, my folks in my local faith groups or racial or ethnic groups or nephrologists or dialysis units don't believe in live donor transplant, that's part of your problem, in addition to part of their problem. The transplant centers need to get out into these communities and change culture. All right. When we think about excellence drives growth, I think about this pyramid because you've got to be banging on all aspects of this pyramid, right? You've got to have great people, you've got to have great systems, you've got to have great relationships, and you have to be innovative. And to be able to run a great program, you have to do each of these in a maximized way. So what do I mean? So sure, everybody knows this, right? The people are the backbone of every outstanding organization, right? Everybody knows that. It's not enough to just show up, right? You have to show up and have a passion for live donor transplant, because live donor transplant is not simple, as I'm going to get into in a minute. But as I go around, if you've got folks that are less experienced or some of the new people, or maybe you don't have anybody assigned at all to really be thinking about live donor transplant all day, if you don't have that person, then you're going to miss out on opportunities for transplant. You need to have somebody whose mission it is to drive live donor transplant. You've got to have experienced people running the program. You know, live donor transplant, because it's complicated, someone's come forward that's healthy that says they want to donate a kidney to somebody. These are complicated decisions that have to be made. There's a lot of risk-benefit that we need to be thinking about. So as I go around and talk to folks, you've got to have your most experienced team discussing these folks. Your most experienced nurses, your most experienced nephrologists, your most experienced surgeons to be able to push proper decision-making to be able to maximize live donor transplant. You've got to have great education processes in place. I mean, we all know that a barrier to transplant is education, right? Now, look, I used to think that we did great education at my center, and you go around and say, oh, no, we do really great education. We have a fabulous video. And then we've got our nurses, and they really do really great education. And so I used to think the same thing until I actually went to our education class and realized that half the people weren't even paying attention to the video. You know, they're on their phone or they're sleeping, right? And then the other half just didn't get it. And then it clicked on me, right? It's kind of like when my son comes home and says, Dad, can you help me do this homework? And I say, how come you don't know how to do this? Like, the teacher never taught me any of this. And I'm thinking, of course they did. But, you know, you just weren't listening, or you weren't thinking about it, right? And our education class is the same way. So when we tell folks in our education class that they need to find a living donor, it needs to be said more than once. And in fact, now we've got separate quarterly programs, which we call End the Wait, which are focused only on live donor transplant, where we do extra education of live donor transplant. We actually have previous recipients and donors come and talk to the patients themselves so that the patients can hear from folks that have come before them. And then we get out into the nephrologist's office, and we don't say fistula first, like the nephrologists like to be thinking about. We say friends and family before fistula, right? Preemptive transplant. Don't be thinking about dialysis, be thinking about friends and family. Friends and family before fistula. So education becomes a really important part of running a live donor program. You've got to have effective screening processes. You have that here. Online donor screening has really changed this field. It used to be donors would have to call, and then you'd have to mail them a consent form, or they'd have to print out some consent and scan it, sign it, email, or fax it back. And, you know, none of that's good. Everything should be done online with DocuSign so that nothing ever gets mailed, nothing ever gets scanned, nothing ever gets faxed. It's just, again, really streamlining processes. Rapid cross-match results in effective planning. This concept that when people want to donate a kidney, they don't mean they want to make multiple phone calls. They don't mean they want to fill out applications. I go to centers, they say, well, you got to fill out an application and all these sorts of things. Donors don't want to do that. Everything has to be screened. The coordination of donor and recipient evaluations should move along. When donors, again, say that they want to donate a kidney, they don't mean they want to take 5 or 6 days off. They don't want to have tests repeated. They don't want to pay for parking. They don't want to come downtown once, twice, or 3 times. They don't want to repeat any of that. So all of this has to be very efficient. When donors have issues that aren't simple, you've got to have processes to overcome them, right? So when the hemoglobin A1C of the donor is 5.8%, is that okay? What about if they've got a small renal lesion? What about a small pulmonary nodule? What if their quantiferon assay comes back positive? What if they're smoking? If you don't have efficient processes in place to deal with all of this, it all gets bogged down, right? And you can't have a committee meeting to make every single decision. And so you've got to have processes or systems in place where every single one of these issues gets dealt with seamlessly so that the donors can get through the process, again, efficiently. You know, the answer to a marginal 24-hour urine result isn't to repeat the 24-hour urine result. I mean, if the donor messed up the 24-hour urine collection the first time, they'll probably mess it up the second time. And so what are you doing to push things along so that things don't get repeated? So maximize live donor transplants, you have to keep an effective pace, right? As I tell people, when someone says they want to donate a kidney, they don't mean they want to donate a kidney in a year or 8 months or even 6 months. They really want to donate a kidney now. And so you need systems in place to allow that to happen because time is against us in this business, right? I mean, donors have a lot going on. You know, they're raising families, they're healthy, they have jobs, and all of this can change. And then, of course, the recipients aren't healthy. Right? So you think you're set up to have a live donor transplant, but it's taken so long, now the recipient stepped on a nail. Or had a heart attack, has some other open wound, or the recipient died. We've had that happen. The recipient looks great, donor finally finishes the evaluation process, get a phone call, recipient died. Time is against us all, but time is really against us in live donor transplant. So I tell people, you have to watch your thinking to doing ratio. Right? Your thinking to doing ratio. If it's too much thinking and not enough doing, nothing ever happens. Right? But you don't want to do too much doing and not enough thinking, right? Because then too much happens. But it is a balance. So you need to move along and watch your thinking to doing ratio. Don't be ordering and ordering and ordering and repeating and making people come back. Make a decision. You've got to have great relationships. You know, I like to show this slide because sometimes it feels like the patient is the sun and everybody on the team revolves around the patient, but we don't intersect enough. And we've got to intersect because live donor transplant takes all of these different groups of folks with different amounts of expertise coming together, and we all have to have the same philosophy. If one group's philosophy is one thing and the other group's philosophy is the other thing, then the patient gets mixed messages and patients don't come through the process. And we need to understand what we're doing. You know, the social workers come from a different angle than the nurse coordinators, than the donor advocate. And then we've got the HLA team that speaks their own language. And we've got to understand what they're talking about. I like to tell this story about how when I was a young faculty in Augusta, I was told that before you accept a kidney for somebody with antibodies, you got to call the director of the HLA lab to make sure that she thinks it's a good match. Fine. So I get an offer for somebody that had a high sensitization level. I call the HLA lab director. I say, hey, listen, I was told to call you. We got an organ offer for this recipient. And the HLA lab director says, oh, thank you for calling me. Yes, I do know this patient. Let me look up his antibodies. Let me see if this is a good match. And she calls me back. And then she proceeds to tell me, well, you know, this overall is a good match, but there's an allele level antibody at A2 I'm a little bit worried about. And then there's this C locus antibody, could cause a positive crossmatch. And then there's some DP antibody. And boy, I don't know, it's a very interesting case. So I'm on the other line, and I'm going, I'm sorry, was that yes or no? Because I'm a surgeon, right? I'm like a binary guy. I'm like, we're operating, not operating, right? But the HLA people, they're not like that way. They're like more like, I've sort of said, like, do you get paid by the word type? You know, it's like a lot of words. But I'm like an operating or not operating guy. And so, you know, it's like, and I'm not making this up. So then after I said that, then she just repeated everything she already told me like I didn't hear the first time. So we're like living in a different world. I'm not interested in anything that she said. I'm only interested in what whether we're operating or not. Like, what sort of risk are we dealing with here? So I just mentioned that because this is really important, that we all need to be understanding what our goal is, what risk tolerance we have, what's our culture, what are we willing to accept. But these aren't things we can figure out at 2 in the morning. So, you know, it takes an enormous number of folks to be able to run a successful live donor program. And again, all of us have to be on the same page. And, you know, we've got to have transparency and metrics. I'm not going to get into this, but I do have a saying that what gets measured gets done, right? What gets measured gets done. And so at my center, we measure a lot of things. So everybody is responsible for a certain set of responsibilities that we've agreed upon. We measure those things and they get done. Because if we don't have those sorts of metrics and we can't measure things, then we never really can gauge how effective we're being to be able to get our patients through the system. So that's a little bit about the people, the systems, and the relationships you need. So let me talk now in the last part about innovation, because a significant barrier to live donor transplant is compatibility testing. So there's a significant margin here. I will tell you the margin for us is almost 30%. So just this one piece alone, you can increase your live donor volume by 30%. So again, significant climb-slide ratio on this. So now I'm talking about this concept of when somebody wants to donate and they're not a match, right? So this is a young man, and I show his picture with permission. He's 17 years old at the time. And he had a previous transplant at another center that never worked. And he ended up with 100% antibody level, and everybody in the community wanted to donate to this young man, but nobody was a match because he had 100% antibody level. And it's sad when you have to deal with these issues. I mean, you basically are telling these folks they've got to be on dialysis until they get lucky enough one day to get transplanted off the list. And so the question is, how do we deal with that? So let me just step back and make sure everybody's on the same page. When I'm talking about matching, right, I'm talking about this concept that we're measuring the recipient to see if there's any antibodies in the recipient's blood against the donor genes, right? Because if the recipient has antibodies in the blood against the donor genes, the concept is that as soon as we take the clamps off, if those antibodies are at high enough level, they'll immediately attack and destroy the kidney, right? So we've got to do some testing to ask, does the recipient have antibodies against the donor genes? Well, why would that be? Well, the most common reason is if they don't have compatible blood types, right? So if you've got antibodies in your blood against a different blood type, that's not going to work, right? And that turns out to be a big issue, right? So the person sitting next to you, if y'all don't know your blood types, is a 1/3 chance they won't be a match, just based on blood type alone. So that's significant. And then if you've ever been exposed to another person's tissues, then your immune system can form antibodies against the genes in those tissues, like a blood transfusion, for example, or a previous transplant. 1/5 of the waiting list has had a previous transplant. Transfusions are very common in the ESRD population, so antibodies are a huge issue. Now, again, how do we measure for these antibodies against the donor? Right, so we do a crossmatch. Okay, everybody knows, oh, is a crossmatch positive or is a crossmatch negative? Okay, so what does that mean? So when we talk about the crossmatch, well, again, what we're asking is if we mix the antibodies in the recipient blood with donor cells, are those antibodies binding to those donor cells? And we can pick up that binding with a fluorescence detector. So let's think about it. So if no antibodies binding, that's easy, negative. We get that. And if huge amounts of antibodies binding, then the fluorescence detector will be really positive. So we think that's not good. But what about if a little bit of antibodies binding? Is it positive or negative? Well, I don't know. It depends on your cutoff. So when I first started in this business, I was like, so what's positive? And they say, well, if the fluorescence detector is more than 80, it's positive. Okay, so if it's 81, it's positive, 79, they were like, then that's negative. I'm thinking, really? That's how it works? That seems odd. Okay, well, but that's the way it works. You have to have a cutoff. People like cutoffs in this business. But what I'm pointing out is that the crossmatch test really is a spectrum. And what we're measuring is antibody binding to donor cells. Again, as a risk of rejection. All right, now, if the crossmatch is positive, we want to know what antibody's binding. or how many antibodies are binding, right? In the past, we didn't have that technology. We just kind of had this old PRA technology. You may have heard, what's the patient's PRA, panel reactive antibody? You know, back in the old days, before we had the single antigen bead technology, we'd ask, how much antibody does somebody have in their blood? And so what we do is we get 100 random donors off the street, really, and put their blood in 100 different wells, and then we take the recipient serum and mix them with all 100 donors. And then we'd ask, out of those 100, how many reacted? And if 100 reacted, 100 out of 100, you say, oh, that's bad. Then their PRA, panel reactive antibodies, 100%. Their chances of matching, 0. If they reacted with half of the people in the community, you'd say your PRA is 50. There's a 50% chance you'll react or have a positive cross-match test with the local population. So this technology wasn't very good for a number of reasons. Number one, the population in Detroit is not the same population as in San Antonio, so your PRA would be different depending upon who the local people were. And the second reason is because you still never knew what antibodies were actually causing that reaction. So now we have better technology. We've got this single antigen bead technology, which is wonderful. And I'm going to talk about this quickly because it's really revolutionized the matching field. The technology now has individual HLA molecules coded to beads that have a fluorescence attached to them, so that when an antibody binds to a specific HLA molecule that's going to cause that positive cross-match, we can see it on a fluorescence detector. And this is what this technology looks like. So this is a patient's serum, and what you can see is each one of these bars is one of those beads that has an HLA molecule on it. So this bead has a B7 molecule on it, and this is a very high amount of binding. And so we say that this recipient has a lot of antibody against the B7 donor or antigen. So that means if this recipient has a donor become available that has this B7, it's not going to work out. It's going to be a positive cross-match. We want to avoid that, right? So this sort of technology allows us to know what antibodies the recipient has so that we can find donors that don't have those antigens, right? That's how this technology works. So when folks come to us and they say that they've got a donor that's not a match, we say we have 4 options for those folks, right? So I like things where there's only 4 options, right? Because that's simple. We can either put them in a computer system and try to find a situation where somebody else's donor can donate to them and they can get a match, and at the same time their donor can donate to somebody else. We can do a paired donation where we can find a better match or a closer match than the person they came with. We can desensitize against the person they came with, or we can tell them, you know what, none of that's going to work out. You should just be on dialysis, right? And so when folks come to us that have a donor that's not a match, we have to choose one of these 4 options. And the question is, how do you choose which option? Okay, well, everything we do in medicine is risk stratification, right? That's everything that we do, right? So if the cross-match is negative, if that test is negative, there's no antibody binding, and there's no what I call DSA donor-specific antibody, that's low risk. We like that. Everybody in the world wants to be there. But what about if the cross-match is negative, so it didn't quite get to enough to get over the positive threshold, but we're detecting low levels of antibody? That's a little bit higher risk. And what about if the cross-match test is positive, so there's so much antibody binding now that the test is positive and we're picking up antibody? Well, if it's barely over the threshold, you might be on the left of this risk stratification, and if it's really positive, you might be on the right, right? So everything we do in medicine has to do with assigning where folks sit and then asking, can we do something to lower risk, right? So every transplant center in the United States has the technology I told you. We all look at the donor and recipient blood types. We all look at the gene profiles, and every center has the technology that I showed you with those small little micro beads to know what antibodies everybody has. Every transplant center in the United States has this technology. So how are we doing in the United States with regard to paired donor transplants, right? What are we doing? So in the United States, the first set of exchange transplants was done in 2000. So this is still a young field. That was done in Boston. And then a couple of more were done in the early 2000s. And then you can see right about 2006, 7, 8, 9, 10, a lot of excitement about this field picking up, right? And now it looks like we're stuck at about 11%. So in the United States, about 11% of live donor transplants or exchange transplants. So that's a baseline for your center. So at your center, you can figure out how many live donor transplants do we do, how many paired donor transplants do we do. If it's less than 11%, you're below average. And if it's more than 11%, good for you. But this is a benchmark. I will tell you that simulation data says that this number should be closer to 30%. So why are we stuck in the United States? Is 11% enough? Is your center doing 11%? Right? So let's look at this. This won't surprise you. KPD transplants are clustered. So this is 2016 data. It turns out in the United States, more than 120 centers did 0 last year. Bad to be a patient at one of those centers if you've got a donor that's not a match. 35 centers did 1. Those are smaller centers. That's fine. Only a handful of centers, 15 centers, did more than 10. One center did more than 40, and that's my center. We did 48. And we don't even participate in national exchange programs. So what are we doing? Again, this concept of how do we move from doing a paired exchange transplant or doing an incompatible transplant to maximizing transplants, and that's all about overcoming barriers. In the United States now, there are a couple of options. If you've got a donor that's not a match and you go to a center, you can be part of a UNOS-sponsored program. So this is a national paired donor program that's run by UNOS. Believe it or not, this was started in 2010. It's now 2017. And last year, the UNOS-sponsored program did 50 paired donor transplants. The entire UNOS program did 50. So my program did 48. There's a national program. There's a couple of national programs. By far the most successful is the National Kidney Registry. They did 399 paired donor transplants last year, the National Kidney Registry, which is fantastic. It's expensive, and there are a couple of other issues that are involved in participating. There are other national programs, some regional programs, and then there are some single center programs that do these types of exchange transplants. The most effective model, I think, depends on the system. There are clearly strengths to these national programs, but there are weaknesses. If you're somebody that likes to individualize, if you're somebody that likes to move at a certain pace, you're going to be constrained by the national programs. So let me show you a little bit about our single center program and sort of how we get these done. I want to just quickly mention, I will tell you, you need a software program to do this. We started to do it with 3x5 cards, but trying to figure out antibody and antigen matching on 3x5 cards is inefficient. So I'm not going to talk a lot about our software program, but you need one. You need a philosophy to be able to put matches together, right? I mean, it seems simple. Okay, well, we're just going to find matches. And it turns out it's not always simple. In other words, balancing quality and quantity isn't always straightforward. Here's an example where you've got two sets of folks, for example, and let's say pair 2's donor goes into pair 1 and pair 1's donor goes into pair 2, and so you like that, we can do a two-way exchange. But then let's say two other pairs come, and it turns out they don't go to each other, but pair 4 goes into pair 1, 1 goes to 3, and 3 goes to 4. So it seems as if everybody would think that's a good idea, which is probably true. Everybody except who? Pair 2. Not good for them. And what about if pair 2's recipient's a child? So do you still leave them out, or would you rather do 2 transplants and benefit a child, or 3 transplants and not benefit a child? So it's not always so simple. And what if pair 2's recipient has 100% antibody level, right? So it's complicated. And so you've got to balance the number of transplants with how sensitized folks are, what the blood types are, what the ages are, and these sorts of things. All right. A little bit about my center. So I work in San Antonio. I like to think of it as a small market town. You know, you go to the grocery store and you still run into people. So about 2.2 million people in the Metroplex, 28th largest market. So San Antonio is not a big city. It's about a third the size of Dallas, about a third the size of Houston. I work in a small private practice hospital. So we have 12 operating rooms in my hospital. It's about 270 beds. Our live donor program did 71 transplants, like I told you. We have no fellows, we have no residents, we have no nurse practitioners, and we have no PAs. We have no in-house HLA lab. We share an HLA lab with multiple other programs. The software we use is free, and it's just 3 sets of folks doing this. So I show this slide to tell you that what I'm going to show you really isn't fancy, right? Every center in the United States should be able to do what I'm about to show you that we've done. So we started our paired donor program in 2008. We've done 393 paired donor transplants. We're going to do 5 more on Wednesday. We're going to, in October, do our 400th paired donor transplant. which is more pair donor transplants than any hospital in the world. Our margin on this, 26%. Again, this is essentially free. There's really no extra support that's needed for this. So really every program in the United States should be doing something similar to this. And again, most of what we're doing are pretty simple. 53 two-way exchanges, 37 three-way exchanges, 8 four-way exchanges. You know, occasionally you get in the news if you do something really fancy. We did a 23 recipient exchange one time and everybody got all excited about it. But that's not the bulk of what we do. The bulk of what we do is pretty simple 2, 3, 4, 5-way exchanges. And that's what it takes to get people transplanted. So let me just give you a couple examples of how this is done. This uses the technology I showed you. So these are 3 sets of folks that have donors that aren't a match. This is a guy that had a previous transplant. Here are his antibodies. We know what antibodies he has because of that technology I showed you. And he's got those beads against these antigens. And see, here's his donor's gene type. His donor is a DQ2 gene, and he has an antibody against DQ2. So that's not a match, right? So not a match. This is an O with an A, not a match. And so the computer shows us that we can do this sort of exchange. And so we get this done. Pretty simple. Everybody in the United States has an A with a B and a B with an A. That's the way we did our first exchange. Our first exchange transplant in 2008, an A with a B and a B with an A. Everybody got excited about it. That's not complicated. Everybody can do that. Occasionally you can fit in another pair, but you don't have to. And then when you've got non-directed donors, somebody that says they want to donate a kidney to anybody, that's an easier situation. Because then you put them into your computer and you say, well, let me find a recipient that they can go into. Right? And so we're looking for the special gene types, and I'm not going to get too much into this, but this particular donor has a special gene type because she only has 1 copy of DQ, it's a DQ2. And it turns out that she went into this 35-year-old school teacher that had 2 previous transplants, and see, this recipient has every DQ except DQ2, which is what this donor is, which is what she needs. So we're able to get that transplant done, and then her donor goes into someone else, and her donor goes into someone else, and you know, these kind of chains go along. This is that 17-year-old schoolboy. Now, he had 100% antibody level because he had every single DR and DQ except his own, and he has DR1 DQ5, which is somewhat of a rare gene type. And so when we see a donor that is DR1 DQ5, we must use that donor for him because it's the only donor that's going to be a match for him. And so that's the way in which we were able to get that young boy transplanted. And then these sorts of exchanges can go on until eventually you run out of folks. All right, so who are we transplanting? Well, we're transplanting pretty highly sensitized folks. It turns out 40% of the people that we transplant with exchange transplants were not a blood type with their original donor. 60% were not a gene type or were a positive crossmatch. 17% had previous transplant, but look at this. More than 50% of these folks that appear in more than 80%, 32% have antibody levels more than 95%. So we're transplanting very, very difficult to match folks with this kind of a program. The reason we're able to do that is because we've recognized 2 things. That pair donation is not a lottery. Sometimes people think when you have a donor that's not a match, you're going to get entered into like some kind of a lottery, like, oh, I hope we find a match. And then you get a call, oh, we found a match. Like it was luck. But it turns out it's not luck. It turns out that it's very predictable. If your PRA is less than 95% and you have an O donor, we transplant every one of those folks. And if your blood type's A and your donor's B, or the opposite, that's just simple. Every A with a B and B with an A gets transplanted, right? So there's a lot of predictability in this business, right? And then the opposite's true, right? So that if you're a blood type O and your donor's a B, like that's a bad combination, right? Because B is a rare blood type, and there aren't a lot of B recipients in the paired donor database. And so B donors are not valuable, right? So O's with B's, O's with A's, not valuable. And then these folks that have high antibody levels, there just aren't enough donors with rare HLA types in the computer system to be able to find matches. And so when you know that, you know how to be able to concentrate to be able to find out how to do more of these transplants. So in the last 15 minutes, I'm going to show some examples of, again, these sort of incompatible transplants, sort of low-hanging fruit, right? How can you, at your center, do simple things that are going to increase your volume by 25 or 30%? So let's look at some really simple examples of things that we see every single day at every transplant center in the United States. So here's the most common reason 2 people are not a match. an O recipient and an A donor. Okay? 45% of the population in the United States is O, and 40% is A. So the most common reason that two folks are not a match is because of this. The recipient's O and the donor's A. And so the question is, now what? Okay, so now what? Well, plan A. Tell him to find another donor. Okay, I like that plan. So call him up, tell him to find another donor. Okay, well, we called him. His daughter's the only one that wants to donate. He has 2 sons, they don't want to donate, just the daughter. Okay, well, that didn't work. All right, well, how about we put him into a paired donor program? O recipient, A donor. Well, I told you, O recipients to A donors just isn't valuable in an exchange program. So neither one of those are good options. Just bad options. So the question is, what should you do? Well, the answer, of course, is you should subtype the blood type A donor. So like many of you may know, blood type A comes in 2 types, right? A1 and non-A1, or A2, right? So 15% of blood type A is A2, and A2 we'll call O-like. In other words, it doesn't stimulate the immune system as much, and so it acts more O-like. Now, most programs in the United States still don't subtype their A donors in their live donor program, and if they don't do that, they're giving up volume, because if the donor's A2, like in this particular case, all you have to do is check the antibody level of the recipient. If the antibody level of the recipient is low, it's actually a compatible transplant. Even though the donor's A, if they're A2 and the recipient's antibody level is low, compatible transplant. If it's 8, which is a borderline titer, it's a simple desensitization. And if it's more than 8, putting an A2 donor into the paired donor database is actually a very favorable pair, and we can get these people transplanted. So the message here is that most transplant centers in the United States, believe it or not, do not subtype their A living donors, and if they don't, they're giving up transplants. And I will tell you, at my center, we do close to 8 to 10 transplants a year simply subtyping A donors, extra transplants a year. It's a lot of volume. All right, now I told you that was only 15% of A's are A2, so what about the other 85%? Okay, fine. So now the donor's in A1. Now what? Okay, now what? All right, well, choice 1. We can enter them into a KPD program, wait for a match. Okay, well, I just told you that's not a good idea. An O with an A, that's a loser. Okay, we can desensitize. We can try to put an A donor into an O recipient. Well, that's a little bit risky. That's a risky blood type combination for blood type incompatible transplant, and then dialysis. Okay, so none of those are good choices. Okay, so now what? Now what? The answer is this, right? The answer is to use a compatible pair at your own center to get these people transplanted, right? So what am I talking about? Well, this is what I'm talking about. So here's the pair, right? We got the O, and then we got the daughter who wants to donate. She's an A1. But the truth of the matter is every transplant center in the United States has the opposite. They have the A recipient and the O donor. And so the question is, what if we ask this pair that has a compatible donor, would you be willing for your donor to donate to somebody else and help this pair get a transplant, and at the same time, on the same day, at the same hospital with the same set of surgeons, same team, allow your recipient to get transplanted with a kidney from a different donor that's younger, using a compatible pair to turn 1 transplant into 2 transplants? And then you could do this. You could use donors that have rare HLA types like I was showing you, and instead of using these rare HLA types to get somebody with no antibody transplanted, say, would you mind using your donor to get somebody with a really high antibody level transplanted, and at the same time you could get transplanted with a kidney from another donor. This idea of using compatible pairs to get incompatible people transplanted. So let me show you some examples. So here's a lady who had a previous transplant. Her antibody level is 99%. Now we're looking and asking, what's her problem? Well, look at all this. Again, she has every DQ antibody except 7, and she's a 7. So she needs a donor that's DQ 7. And then she's got these other smattering of antibody. This is her donor. She's not a match with her donor because her donor is DQ28. She has antibodies against 28. But now here's a compatible pair. Right? So this compatible pair, this donor, has the donor gene type that we need. Now, this donor is a match with the recipient, but we're going to ask this pair, is it okay if your donor could donate to this lady who really needs a transplant, and in exchange, your recipient gets a kidney from a younger donor, right? Again, taking 1 transplant and turning it into 2. Here's a situation that's somewhat similar. We finally found a donor for this recipient, but nothing's ever easy in this business. So this donor's O, so this is no good, so we're stuck. So we use a compatible A with an O to fix this, and now we're turning one compatible transplant into 3 transplants. Right? And it can even get more complicated, right? So here's 5 sets of folks that I worked on for a long time, and it turns out all this looked really great, except for the fact that this recipient did not go into this donor did not go into this sensitized recipient with an 84% PRA, so I was stuck. So we put a compatible pair in, and it turns out that this donor does go into this recipient, and this recipient gets a kidney from a younger donor at the same time. So now we've taken one compatible transplant and turned it into 6 transplants. So using compatible pairs turns out to be very powerful. We've used now 49 compatible pairs. They've been involved in 158 KPD transplants. When I first thought about doing this at my center, people said, that's a terrible idea, Bingaman, we're not doing that. Nobody's going to agree to that. And when everybody thought it was a terrible idea, I knew it was a good idea. It had to be a good idea. Right? Why would it not be a good idea? Taking A's with O's and putting them with O's with A's, who's against that? I don't disagree. We didn't have a mechanism to do it. I don't disagree. Some people are going to say no. But what if one person says yes? What if 2 people say yes? You see? So this starts the process. So I will tell you at my center, guess what % of people say yes to compatible exchange? 2/3. Okay. 2/3 say yes. It's just the psychology of the donor. So we've been able to use compatible pairs in a very powerful way. Now look, I get that using compatible pairs in a national program is worrisome, right? Because you work up the whole pair, and then instead of transplanting them, you like put them in a computer system somewhere. And you say, yeah, well, we're going to call and see if we can find a match. And then these national programs have lots of conference calls, and you have to have conference calls about doing the match. And then you got to figure out how the kidney's going to get imported, and then some other donor surgeon's going to take it out. You take it out of the box, and you're going, well, the kidneys we do look way better than this. And so everybody gets all nervous about using compatible pairs in national programs, and I agree with that. So compatible pairs are really best used at your own center. So when you have O's with A's and you have A's with O's, put them together, right? That's not complicated. Do it at your own center. All right, a couple more examples I want to show, because these are really simple. Here's a lady who's a B with a B. This is actually her boyfriend who wanted to donate a kidney to her. She's had multiple pregnancies, and we get the crossmatch report, and the crossmatch report said that the T crossmatch is positive and the B is negative, and the question is, now what? Okay, well, now what is, well, what do you mean by positive? I don't know what positive means. I want to see some raw data. So I say to the HLA lab, I want to see more information. The HLA lab says, okay, here's your information. Okay, well, let's look at it. Well, this recipient has a lot of antibody, clear on that, has 100% PRA, fine. Now, look at this. So this is the recipient. This is actually her boyfriend. They're perfect gene matches, believe it or not, at everything except A. So they match everywhere except A. And the boyfriend's in A11, and she has an antibody against A11. But it's a low bar antibody, 1300, it's one of those low bars. And the crossmatch test is only positive, but just a little bit over the cutoff. Fine. So now we have a B recipient and a B donor. I told you B donors are no good in paired donation. The recipient already has 100% antibody level. And so the question is, what do we do with this pair? So we could put them into a paired donor program and wait for a match. Okay, that's a loser, right? The recipient has 100% antibody, that's a loser. The donor's a blood type B, that's a loser. Dialysis, we hate dialysis, right? So the answer is, this is a very simple desensitization case, right? So some centers say, oh, we don't do desensitization. Okay, well, this is simple, right? This is a low-level antibody, a weak positive cross-match, in somebody with 100% antibody level. So this is a very simple, low-risk desensitization to be able to get these folks off dialysis. You've got to have a center that's willing to do low-risk desensitization. All right, this is a case we did a month ago. This is a 24-year-old young lady who lives in Laredo. And she's been on dialysis for 3 years. And she couldn't get transplanted, even with a national matching system, for 100% PRA people. She's got all this DP antibody too, by the way, which isn't put into the national computer. Finally, her sister came forward. You know, her sister didn't come forward before because somebody told her she knew her blood type, that she wasn't a blood type match. Okay, well, it turns out she's not. The recipient's an A and the sister's an AB. And so now what? Okay, we tell them no, not a match. Find another donor. Or how about this? So I thought, you know, it's a sister. Let's check the HLA type. And it turns out, guess what? The sisters are HLA identical. She has 100% antibody level. Okay, now we've got some action, right? So now I've got an HLA identical sister with a different blood type, an A with an AB. So what? So check an anti-B titer, it's low, and so we're able to do a very simple blood type incompatible transplant to get this young girl transplanted with 100% antibody level and a perfect gene match. ABs into A's is a very simple blood type incompatible low risk transplant. So her creatinine's 0.8. All right, now another simple case. So we've already kind of covered this, right? So here's a lady, a 93% PRA. She's got one donor. She's got 2 antibodies against the donor. These are strong positive cross matches, so that's going to be no good. So the question is, what do we do, right? And so we've already covered this, right? A 93% PRA with an O donor. Everybody gets transplanted with a paired donor transplant. Very, very simple. So when you see these people, you tell them you're going to get transplanted as if you were a match because it's so simple to transplant these people. A couple last examples. This lady's from Houston. And she came to us because she couldn't get transplanted in Houston, so I spent extra time on her. And when I saw her antibodies, I said, you got to be kidding me. I'm never going to find a match for her. She was on dialysis for 17 years and couldn't get a match because look at all those antibodies she's got, right? And so here's her cross match, very strongly positive, so that's going to be no good. And the problem is with these people is that none of the conventional things we do work, right? They can't find a match in paired donation. They can't be desensitized. It's too strong. Dialysis we hate. These people don't get transplanted off the national list because they have too much antibody. And the question is why? And the reason is because if you tell the computer that they have so many antibodies, because remember, these are human beings putting into a computer system what antibodies the recipient has. And if you tell the computer, yep, they have that antibody, yep, they also have that, yep, they have that, yep, they have that, yep, they have that. You tell the computer they have every single antibody, you're never able to allow the computer to find a match because you've made the target too small, right? If your PRA is 50%, if you don't match with one person, you'll match with the next. But when you tell the computer somebody has antibody against everything, they never find a match. And it turns out if your PRA is more than 99.95%, those people still aren't getting transplanted with national priority, right? So you have to take more risk for these people. You have to tell the computer that they don't have antibodies that they actually do, right? You're going to be willing to transplant people across some low-level antibodies. You're willing to take more risk. Well, sure, I get it. You know, a little bit more risk is more complicated. It does take more time. It's a little bit more expensive, and it's possible that they might have an increased risk for a bad outcome. But the thing is, we've got to be able to understand that all risk is relative, right? These people are on dialysis, right? They're willing to take some increased risk, and right now they have no other option because they're not getting transplanted off the list. We want to be able to take calculated risk, right? We want to be aggressive, but we don't want to be crazy, right? And we have to be smart enough to know the difference, right? So how do we do that? Well, again, we want to find a situation where the cross match is, you know, kind of weakly positive. We want to be like kind of living here, right? So quickly I'll end by saying that, you know, the transplant community, in my view, has gotten this wrong over the years. That's why desensitization is a bad name. People say, oh, we don't do desensitization. It's too risky, you know? And I think the reason is because of this. So I like Sun Tzu. So he's the great Chinese general. And he said the following. He said, victorious warriors win first and then go to war, while defeated warriors go to war first and then seek to win. So in the transplant community, there were these centers that would do all this desensitization, and they would give the patients all kinds of medicines and desensitization and pheresis, and then they do a splenectomy, and then they might give some drug called eculizumab, which costs $500,000, and then half the patients would do well, and then they'd publish a big article on it into acclaim. And most people are going, I would never do that. Well, right, you shouldn't do that. Right? The idea is that you should try to avoid all those problems, right? The idea isn't to just do a transplant and then hope it works out. The idea is when you think about the phases of risk, don't think about how am I going to treat the consequences of something bad happening. Think about how am I going to choose the appropriate risk so nothing bad happens in the first place. Right? That's the idea. And with paired exchange, we're able to look in our database and try to find a low-risk donor so that we don't end up having to deal with these terrible complications of terrible antibody-mediated rejections. The era of high immunologic risk transplants in 2017 is over, right? So we want to look for close matches in the computer system. So here she is, and what our computer shows us is this donor that she's a perfect class 2 match with. Now, she has 3 antibodies against this donor. I don't worry so much about the DP antibodies. They seem to be less dangerous. So she's really got 1 antibody I'm worried about, and we do a crossmatch, and the crossmatch is positive, but it titers down to negative at a 1:16 dilution, which puts it at low risk. And so this is a way in which we're able to find close matches to be able to get patients like this transplanted. So you've got to be able to look for close matches to be able to get these sorts of transplants done. This is a lady from Dallas. I couldn't find a match for her. Similarly, she's in B. I put her in as a blood type AB, and then when I did that, I found this donor. So again, it's a simple blood type incompatible transplant to get her transplanted. And then one final example, which makes an important point, is this is a guy that we transplanted that had 2 low-level antibodies, titered out to negative actually at 1 to 8 and 1 to 2. So this looks like a good situation. We do give pheresis and IVIG. These are the antibody levels before we desensitize. This is the day of transplant. So things are looking good. My surgeon's feelings here, good feelings. But then on day 5, bad feelings. Right. So when you do these transplants, things go bad quickly. They don't go bad slowly. So on day 4, creatinine 2.8, day 5, creatinine 3.5, antibody levels 17,000. 17,000. Day 6, bad feelings. Day 8, bad feelings, right? So these things go bad quickly, but you've got to recognize them early, and you've got to be able to treat early and aggressively so that you're able to turn these sorts of things around. You know, I like to say chance favors the prepared mind, right? So if you're going to do these sorts of things, you need to be prepared. Since 2009, we've done 60 live donor transplants in people with PRAs more than 98%, 38 with PRAs 100%. Almost all these people we've transplanted with KPD, and yet our 1-year patient graft survival is outstanding. I've never lost a kidney from antibody-mediated rejection in this group of folks. So more work, more resources, more risk, more transplants. These are the transplant centers since 2009 that have done the most number of live donor transplants in the United States, and they're centers where you'd expect them to be. The Mayo Clinic, Cornell, Northwestern, UCLA, UCSF, Columbia. These are the biggest programs in the United States since 2009. But by far, the biggest live donor program in the United States is at a small private practice hospital in San Antonio. So what this shows you is that opportunities multiply as they are seized. You've got to overcome barriers to transplant more patients. You've got to recognize that if you're excellent at every facet of live donor transplant, the excellence will drive growth. So donors are the true heroes in transplant. We all know that. It's remarkable to me that people come to us and say they want to give a part of their bodies to make someone else live longer. And we in the community have to recognize what a precious gift that is. We need to honor that gift with our work. It's why we work so hard. It's why we have the passion to do what we do, is really to serve the donors and to serve the recipients. This is a lady that came to us and said she wanted to donate a kidney to anybody, and we put her into our computer system and started that 23-way chain. And so because she donated her kidney, 23 people in South Texas are off dialysis. Well, this is a lot of work. It's not a lot of work that anybody can't do, but it does take a tremendous amount of dedication. And I'm certainly grateful to our team. Kathy Murphy is the head of our HLA lab, who spends countless hours with me on this Incompatible program, and the entire staff of the hospital. We can only be as excellent as the least excellent amongst us. So I tell people I demand A+ workers on my team, and I'm really grateful to my A+ staff. Thanks very much for the invitation. It's been a lot of fun. Thanks.
Thank you, Dr. Bingaman. The floor is open for questions. Jason?
Thank you for providing some of the nuts and bolts of the KPD programs and other programs, as well as some of the innovations that get you exponentially increasing transplant. Two main questions. Do you involve ethics committees routinely when you use any particularly compatible pairs, or do you just have a protocol that you establish with ethics committee? One, and all the examples you used, the compatible pair was getting a sort of a benefit from a younger donor. Is
Okay, that's a good question. So the question is surrounding compatible pairs. So I would say two things. We started using compatible pairs in 2008. It's a different field today because many centers are now doing this. When we started, I had similar concerns as you. So we started with an IRB approved protocol. So that gave me the protection that we needed. And I would encourage you, if you had some reluctance in your community, if it's approved through an IRB, then that's great. So that means it's vetted, you've got a special consent form, and so that's the way we started, is through an IRB approved program to use compatible pairs. The second issue is regarding younger kidneys. So that's something that we put into our original protocol only because I wanted to be certain that people were clear that they're getting a kidney at the same time from what I'm going to say is a non-inferior donor. So I never tell folks that the donor they're getting is better, because I don't believe that. What I do tell them is that the donor is younger. That doesn't mean it's better, but it's a kidney from a younger donor. Now, obviously, we exclude perfect gene matches, we exclude perfect DR matches, but it's something that makes sense to people. And that's the way we've chosen to do it. Now, having said that, I've been criticized. People say, well, why do you have to get a kidney from a younger donor? Donors have autonomy. They can do whatever they want. But I would be worried if I used a compatible pair and gave the compatible recipient a kidney from an older donor, right? That just doesn't stand to reason. So we've just done it that way right from the beginning. The IRB thought that that was reasonable, and so that's the way we've always approached it. But we don't tell people they're going to get a kidney from a better donor. We just tell them they're going to get a kidney from a younger donor.
Other questions?
Yeah.
Yes, please, Carol.
Yes, did that young 17-year-old man, did he ever get a kidney?
Yeah, so he was part of that big exchange. He was that one that needed that DR1 DQ5 homozygous donor. And I point that out because, again, not all donors are created equal. And when you look at the donor HLA type, you don't want to use a donor that has a rare HLA type for a recipient that doesn't have much antibody, right? Because if you have a very valuable gene type of a donor, you want to use that in a recipient that really needs it, right? And so that's a really good example where that recipient, that boy, had antibodies, except you don't form antibodies against yourself. He had antibodies against every DRDQ that wasn't him. And so he actually had a rare gene type, the DR1 DQ5. And so when we saw we had a donor like that, we would only use that donor for him. And yeah, it's been wonderful. We actually did that transplant back in 2010. He went on to college and has graduated and is now, he was living in Vermont at the time, now in North Carolina, but his whole life has been changed by this sort of technology.
Neat. Jason?
Being at what seems to be a smaller hospital, do you think they gave you more autonomy on how to make changes quickly as opposed to being part of a really large system, one? And what percentage of the change in your live donor program numbers you think came from just the immunologic innovation that you did versus staff engagement and process?
Yeah, well, those are great questions. So the first question, the answer to the first question is, yeah, I think that the small, I mean, look, it's my sense that the fewer number of people you have at a meeting, the more you can get done at the meeting. Okay? I have 3 people at my paired donor meeting, me, a nurse, and the HLA director. I mean, other people can come if they want, but the fewer people at the meeting, the better, right? I don't have 20 people that have to sign off on everything that I want to do. So I personally, myself, plan every single exchange transplant that we've ever done, almost 400, and I don't have to ask anybody's permission. If I did, then we'd never do anything, because everybody would have a different opinion on it, right? So I don't work in a vacuum, and you have to build buy-in, but I don't disagree that a smaller team that's focused and empowered, I think, can be more effective than a huge team where everything has to be vetted. I agree with that. Now, the question is the yield. So the yield is about what I said, and it's both. So we went from 71 to 162. Okay, so we more than doubled the size of our program, but the incompatible piece of that is about 30%. So the rest of it is great people, great systems, and great relationships, and then some of the other innovative things that we do that I didn't talk about to really push the field forward. So So it's about 2/3 people systems relationships, 1/3 incompatible transplant with regard to the growth.
Thank you. Other questions? Great. Well, thank you so much, Dr. Bingaman. That was wonderful.
Yes,